Good morning, good afternoon, good evening, everybody. We are very happy to be here today and in that webinar, in the ISSM webinar, and that will speak about healthcare disparity in minority population. Next slides. We have a translation. The ISSM webinar now have the option to add automated subtitles, including translation. You will be able to turn this on and off at your convenience. You can select the language of your choice via your own screen. To do so, at the bottom of your screen, next to the chat and Q&A, you will see a third button, Show Captions. Please click this button to select the language of your choice. My name is Sharon Pelegnesher. I'm an oncology nurse and certified sex therapist. I work at the Tel Aviv Medical Center in the oncology department as a sex therapist, and I'm the co-owner and CEO of Rotem Center. It's the Israeli Center for Sexual Medicine.
You. And I'm Don Lee. I'm a urologist and andrologist working in London, United Kingdom, primarily based at University College London Hospital.
The ISSM vision, we believe that because every human being has the right to a healthy and satisfying sexual life. The mission and the purpose of the ISSM is to become the most respected and trusted source for information, education, and professional development in the field of human sexual health. We achieve this through the delivery of world-class publications, research findings, and both online and in-person opportunities of knowledge exchange worldwide. Here we can see all the affiliation of the society, many. We can be very proud of that. Next slide. We also have a few journal. Next slide.
Great, and it gives me pleasure to introduce the Sexual Medicine Society of North America, or the SMSNA, and very similar to the ISSM, because they're one of the affiliated societies, that the objective is to promote, encourage, and support the highest standards of practice, research, education, and ethics in the study of human sexual function and dysfunction. So all the members are committed to sexual health and are made up of physicians, clinician, research scientists, APPs, allied health professionals, technicians, social workers, and so it's a very broad church to all who are dedicated to sexual medicine. Next slide. So what we do as a society is we identify and any emerging issues in the field of sexual medicine and sexual function and dysfunction. And we then provide a forum for the free exchange and discussion of new ideas, thoughts, and concepts in sexual medicine. We also develop standards and guidelines for sexual medicine research and practice, and we bring leading concepts of research, clinical practice, ethics, and politics to health professionals interested in sexual medicine and sexual health. Next slide. So this is the strategic plan from 2023 to 2027. So we're halfway through the strategic plan. And the vision of the SMSNA is really to provide optimal sexual health to all. And the mission is to innovate, educate, and inspire the best practices in sexual medicine. You can see there the 6 guiding principles, and I won't go into too much detail, but it is there available on the SMSNA website if you want to read more into this. Next slide. So without further ado, we'll start with the formal program for the evening. First, with Professor John Mulhall, who will be speaking on prostatectomy, and then Professor Bart Burnett, who will then speak on racial disparity research. And we will follow with a Q&A session. Next slide. Now, please, if you do have questions, feel free to use the Q&A button at the bottom of your screen rather than using the chat, because if you use the chat, the questions may be lost. And also, if you could, please add the name of the speaker to whom you are addressing the question. It just makes it a bit easier for us to direct the questions. The Q&A will start straight after the presentations. Also, we are recording this webinar, and therefore, by participating, you are giving consent to be part of the recording. Next slide. So we'll start off with Professor John Mulhall, who will be speaking on sexual dysfunction after radical prostatectomy. So he is the director of the Sexual and Reproductive Medicine Program at the Memorial Sloan Kettering Cancer Center, a very respected researcher, clinician, and I look forward to his talk. Please, John.
Thank you, Don. Thank you, Sharon. It's my great pleasure to be here. I'm Secretary General of the ISSM, and I'm a past president of the Sexual Medicine Society of North America. So I bridge both societies. I work at a cancer center, and I am deeply involved for the last 3 decades in oncosexology, that nexus between cancer and sex. Next slide, please, Siobhan. These are my disclosures as I'm wont to present. I have no conflicts in this presentation. Next slide, please. There is nowhere in the prostate cancer journey where sexual dysfunction is not a potential problem. So, for example, the diagnosis alone can cause sexual dysfunction. Patients on active surveillance often end up getting erection problems, and certainly any definitive therapy, adjuvant therapy, can cause problems also. So along the entire prostate cancer journey, sexual dysfunction is a significant concern for patients and for couples. Next slide, please. So sex is a multifaceted activity, and to claim otherwise reeks of obsessive penocentricity. So for decades, we have focused our attention on erectile dysfunction when in fact there are other sexual dysfunctions that are important to talk about, and that will be a significant focus of my talk today. Next slide, please. So this is looking at patients. We published this from Memorial Sloan Kettering. This is looking at patients over the course of a 2-year period, looking at a bother score, where the lower the score, the greater the degree of bother. And you can see that if you look at the ED group, that even though there is improvement in bother, their bother is still high. Even though they, the non-ED group, I should say, even though they have recovery, that their bother is still high. So why is that? Next slide, please. So I think you're all familiar with this list of sexual problems, and I won't go into detail on all of them. And you can see the literature prevalences here. So ED, for example, 3 to 90%. But I want to show you the next slide. Next slide, please. And this is looking as of October 24, so it's not very recent, but about a year ago, at the frequency of searching for these sexual problems. And yes, of course, 523,000 searches for erectile dysfunction. But if you look down at changes in orgasm, low sex drive, and penile volume alterations, you can see they have massive amounts of searching going on. So it's not just about erectile dysfunction. There are other sexual dysfunctions that reduce a man's quality of life, even if he has good erectile function recovery. Next slide, please. So erectile function recovery does not necessarily translate into high sexual or life satisfaction after prostatectomy. Depression and bother post-RP in some men is unrelated to erectile function recovery, and the source of such bother is multifactorial. And I would say very frequently, and I say it to my oncology colleagues at Memorial, the sexual medicine teams give more bad news than many urologic oncologists in the prostate cancer space. Next slide, please. So I think it's important that we start expanding our explanation, and our first dip into this was the work that I did with Stacey Loeb, which is looking at the impact of prostate cancer on female sexual function. And we actually validated this questionnaire, the SKIP-F. So I think there's lots of work still left to do 40 plus years after the introduction of the nurse-bearing prostatectomy by Dr. Walsh. Next slide, please. And if you're interested in this area and defining and reporting erectile function outcomes and how the literature varies so much, this is a reference, a paper that I wrote many years ago on how to interpret this literature. Next slide, please. So this is a meta-analysis. I believe the best meta-analysis that exists in the literature. It comes from Memorial Sloan Kettering, and it looks at all the literature on erectile function recovery after radical prostatectomy, something in the range of about 1,200 abstracts, and 22 made the cut English language 2-year follow-up, validated instruments. And if you look at the bottom of the screen, you'll see that somewhere between 50-55% of men have erectile function recovery based on validated tool assessment with or without a PDE5 inhibitor at 2 years after surgery. And that's a reasonable number to give to our patients when they walk in the door. We know that there are many different factors that impact upon erectile function recovery, but that would be a reasonable starting point in your discussion with patients. Next slide, please. If you look at back to baseline, there's very little literature on back to baseline. These are men with excellent erections, EF domain score of 24 or higher at baseline. And if you look at age, and if you look at men over 60 years of age, you can see that only 4% of men get back to baseline without the use of a PDE5 inhibitor. And we can elevate that number to a mere 16% with the use of a PDE5 inhibitor. So in men who come in to see me, the average patient who's going to have a prostatectomy over 60 years of age, men come in, they have a very unlikely chance of getting back to their baseline function. Next slide, please. Are we doing better? Red is open prostatectomy, blue is robotic or laparoscopic prostatectomy. We published this a few years ago. You can see on the x-axis years after surgery, and you can see that we're actually not doing a much better job, that with the advent of robotic surgery, it does not look like that we're directly impacting in a positive fashion on sexual function outcomes after radical prostatectomy. Next slide, please. What about the chronology? Very briefly, based on neurobiology, the optimal recovery of erectile function occurs somewhere in the 18 to 24-month time period after surgery. Do we see men who are 6 to 9 months after surgery who are robust pill responders? Absolutely. Is that the routine? No, it is not. It's important to understand that the nadir, the low point in erectile function after prostatectomy, is about 3 to 4 months. And there is a group of people at our institution, about 10% of men, who have documented improvement beyond the 24-month mark. Next slide, please. The pathophysiology, I think, is well known to you. Neural trauma at the time of radical prostatectomy, endothelial damage as a result of the neural trauma, and this is why we're using PDE5 inhibitors in the rehab space as an endothelial protectant. But the final common pathway to permanent ED, venous leak development, is collagenization of corpus cavernosal smooth muscle. That is the permanent effect, that is irreversible. And if you believe in rehab, this is why rehab should be started early to prevent these structural changes in the smooth muscle. Next slide, please. Cavernosal oxygenation is the concept that your penis is a large vein in the flaccid state and a large artery in the erect state. And in that balance between flaccidity and erection, those 3 to 6 erections that we get nocturnally every night after puberty, there's a balance between oxygenation and hypooxygenation. However, in a man post-prostatectomy who has a period of sustained unantagonized flaccidity and hypooxygenation, everything shifts in favor of collagenization, fibrosis, and the venous leak concept that I referred to a few minutes ago. Next slide, please. This is a diagrammatic representation of the corpus cavernosum, and you can see black is tunica, blue is smooth muscle, and the subtunical venules, as that muscle expands under nitric oxide control in a 3-dimensional fashion, the subtunical venules get compressed. And that is the veno-occlusive mechanism. There are only 2 things that keep this muscle contracted: adrenaline, the world's most potent anti-erection chemical, and collagenization of the smooth muscle. Next slide, please. This is data from many years ago, 96 partner corroborated patients with excellent erectile function. And this is looking at the time course of the development of venous leak. That venous leak development is a time-dependent phenomenon. The later you wait to intervene, the more likely men are to have structural changes in erectile tissue. Next slide, please. Why do we care? Because if you look at the far right-hand side, when you have venous leak, it portends a very poor prognosis for recovery of natural erections, of pill-based erections, PDE5 inhibitors, and even intracavernosal injection therapy response. Next slide, please. So, the predictors of erectile function recovery: degree of nerve sparing, baseline function, patient age, but also increasingly we are aware of surgeon experience and surgeon volume and the presence of medical comorbidities, especially the presence of diabetes, obstructive sleep apnea, and very low T levels. These are independent predictors of poor recovery after radical prostatectomy. Next slide, please. There's a nomogram we have at Memorial that predicts erectile function recovery, and everyone takes a hit. If you take a 40-year-old man with no comorbidities and perfect baseline erectile function and perfect nerve-sparing score, those patients take a 6-point hit on the IIEF erectile function domain score. So everyone takes a hit on their erectile function. Next slide, please. So penile rehab is the concept where we're the use of any drug or device to maximize erectile function recovery. Next slide. And what are we really trying to accomplish with rehab? Without going into great detail, to limit structural alterations, to prevent venous leak development. And I tell all of my patients, we're not trying to just make you functional again. We're trying to get you as close as we can back to your baseline. And you saw earlier on that, especially men over 60 years of age, the likelihood of getting back to baseline without rehabilitation is extremely low. Next slide, please. So the bottom line is, given the potentially devastating consequences of acute onset long-term AD after prostatectomy, should we not be discussing rehab with these men while we wait definitive evidence confirming or refuting its benefit and thus facilitate the patient making the final decision? There is no area in medicine that I know of that is more shared decision-making than this entire concept. And we should be avoiding parentalism in forcing patients down one pathway or another. It is the patient or the couple who make a decision about rehab. Next slide, please. Very briefly, there are 4 papers now in the literature. The first one suggesting biochemical recurrence rates are higher with the use of regular PD-5 inhibitors, but there are now 3 excellent papers. The Montorsi group in Milan, the Swedish registry, Stacy Loeb's paper, and then the Memorial data here, where regular use of PD-5 inhibitors does not increase the risk of biochemical recurrence after prostatectomy. Next slide, please. So the future, I think that, of course, things that are going to give men erections protect erectile tissue, but I'm intrigued by the concept of neuroprotection, and perhaps we can ask Bud a question at the end, because Bud is in the throes of a study to look at neurostimulators, which is very exciting in this space, and it is my hope that we'll have either systemic or locally applied neuroprotective agents or devices that improve erectile function recovery over time in the future. Next slide, please. So what about other sexual problems? Well, changes in the nature of orgasm. 10% of men have increased orgasmic intensity, 50% have decreased orgasmic intensity. There is a proportion of patients who have anorgasmia after radical prostatectomy. That is more psychologically mediated than anything else. 15% of men have orgasmic pain, penis or testicles, at least in a very short-term period after radical prostatectomy, averaging about a 3 to a 4 and a 10-point pain scale. And then, of course, the concept of sexual incontinence and climacturia, orgasm-associated urinary leak. Next slide, please. And the literature on orgasm changes go back many, many years. And this is just a very brief summary. The Jennifer Barnes paper, which is from Cornell during my time there, 2004, 37% of men were anorgasmic at a time point 1 year after prostatectomy, 37% decreased orgasmic intensity, 4% increased orgasmic intensity, and a 14% orgasmic pain phenomenon. Next slide, please. If you look at orgasmic pain, you'll see it's mostly confined to the penis or the testes. And if you look at the proportion of patients still complaining of pain over the course of time, it is less common in the 2nd year, and it's very rare in the 3rd year. Next slide, please. Ejaculation at the time of orgasm, climacturia, Neil Fleshner coined that term many years ago, related to bladder neck incompetence, most probably, and possibly urethral anatomy, reduced urethral length or urethral width. It occurs in up to 90% of men at least one occasion post-prostatectomy. At Memorial, 60% of men have this problem on at least one occasion, 20% consistently in the 1st year. The volume is highly variable from drops to ounces, and it invariably resolves over time. But the distress is not insignificant for men, and especially for the partner. So in the first half dozen orgasms after surgery, we tell Mr. Jones, avoid oral sex and have a towel on the bed, lest you leak urine during orgasm. Next slide, please. This is just the literature on climacturia going back some years, and you can see that the literature would suggest that there's no significant predictors that we've been able to identify at this point in time. Next slide, please. What about arousal incontinence? Very interesting phenomenon where unrelated to orgasm, but during sexual stimulation, men start leaking urine. This is sphincteric incompetence, almost certainly, and is directly related to diurnal continence in the patients who have it. The volume is usually low, but the bother is higher. Why? Because it's not very predictable. At least climacturia is predictable because it occurs at the time of orgasm, but this phenomenon is not predictable and tends to be more bothersome for many patients. Next slide, please. We use this penile constriction device, particularly for men with climacturia. Just remember, if you're using penile constriction bands, rubber, never metal, apply over the erect penis. Variable tension devices are more comfortable and they should stay on the penis for no longer than 30 minutes. If you have good erectile rigidity, these devices work extremely well in preventing climacturia. However, if you don't have good erectile rigidity, they tend not to work well because you need a backboard against which to compress the urethra. Next slide, please. What about libido loss? Well, in general, there are only 3 causes of libido loss: endocrine, medication-related, and psychological. So for any man who comes into you with low sex drive, these are the 3 things that you should be hunting for. Do they have an endocrine problem? Are they on any offending medications? Are there any psychological factors that are impacting upon them? If you look at men in my practice who have psychologically mediated reduction in their sex drive, invariably it's related to bad erections, that we become avoidant when we've got bad erectile function, often perceived as libido loss. Next slide, please. We're going to look for pre-existing libido issues. Is it related to PS anxiety? Is it related to their continence, whether it's sexual or diurnal? Is it related to their ED? What is their T level? And of course, an interesting question is, does prostatectomy or radiation therapy drop serum T levels? There's no good evidence to show that prostatectomy does, but there is some evidence to suggest that T levels after radiation therapy, even in the absence of ADT, may in fact result in lower T levels. And then, of course, we all know that there's a proportion of men who on ADT never recover normal testosterone levels. Next slide, please. What about penile length alterations? This is a fascinating area if you're into research methodology. There's all kinds of issues that are at play here, especially the, is it blinded? Is it a single evaluator? What's the intra and inter observer variability in penile length measurement? But if you're interested in penile length measurement, you should most probably be going from bone, pubic bone, to cornal sulcus. And there are 2 fixed points, and that's probably the most accurate means of assessing penile length. Next slide, please. And this is the body of literature that exists on penile length after radical prostatectomy. The Baruchan paper comes from Memorial Sloan Kettering. And very interestingly, 41% of men had no length loss. This was single evaluator pre, 2, and 6 months after prostatectomy. And most interestingly, the only predictor of no length loss at 6 months after surgery was the use of daily PD-5 inhibitors, which is entirely consistent with the REACT trial data, which showed actually preservation of penile length/volume in those patients using daily Cialis during that randomized placebo-controlled trial. Next slide, please. So with that, I'll hand it over to Bud.
Yes, good afternoon, everyone. Delightful to be able to join in this webinar. Are you hearing me well? To make sure the audio is on?
Yeah,
yes?
We can hear you.
Okay,
Great.
beautiful, beautiful. Thank you. Well, Sharon and Don, thank you for co-hosting. It's my delight to join with you. And
Do you want me to introduce you?
Well,
you can do it by your own. Great.
Yes, I'll self-introduce.
Okay.
By way of introduction, my name is Arthur Bud Burnett. I'm a professor of urology at Johns Hopkins School of Medicine, which is in Baltimore, Maryland, United States. I have also participated in the sexual medicine societies for many years. I'm currently the treasurer of the ISSM, and I've been a former president of the SMSNA. So again, much as John described, I kind of have a foot in both societies and very keen about promoting what each society is doing. It's certainly delightful for me to participate in this webinar, and my presentation will complement some of the information John has shared. It is focusing on the aspect of healthcare disparities in minority populations and give you a sense of racial disparity research about that. And as was said early on, sexual health and sexual medicine is a right, and then we should make sure that as healthcare professionals that we meet the goals of everybody from all sectors of society that have sexual dysfunction. And so this talk generally fits that discussion, which certainly is consistent with my interests over many years. Next slide, please. So by way of disclosures, I mentioned some of the entities with which I do have some scientific collaborative and partnership activities listed on the slide. Next slide. So by way of outline, what I'd like to present to you is to review racial ethnic disparities in healthcare, give you a sense of how we define it, what are risk associations. We're going to speak a bit about sexual health in the setting of prostate cancer management. So I'll talk a little bit about prostate cancer, which is a very prevalent disease state. And then some interesting observations that have to do with health burdens and health economics surrounding this topic area. And then delving really more specifically into the discussion on sexual health. What is the hypothesized occurrence and significance of adverse sexual dysfunction outcomes in African American men in the setting of prostate cancer treatment? Are they worse affected? Are they similarly affected? How do we assess this and how do we manage it? And I do think we have to have some consideration within a cultural context and psychosocial context of this population. And then toward the end, I'll talk to you about how I view how we can go forward with approaches that can encompass various areas from healthcare research to policy and so forth, but mainly the research side of it in terms of how we will move forward to address sexual dysfunction in the setting of prostate cancer treatment in African American men. Next slide. So just by way of background, there are healthcare disparities, certainly describing the situation in North America, but certainly perhaps around the world. A definition is the increased burden of an adverse health outcome or health determinant within a specific subset of the population. And there may be a variety of aspects to this. There are disparities along the lines of patient, provider, and healthcare system. Patient may have a variety of biological factors, behavioral and cultural factors. Provider may be some biases and factors along those lines, along with access to healthcare. And I'm going to touch on some of that within this presentation. Next slide. Now, I just wanted to almost state from the outset here an observation about how we are making scientific progress in medicine and how it affects different populations. And I think there's a salient observation by a good colleague of mine, Otis Brawley, who stated that when population disparities always increase when there is the scientific progress in medicine. So just a pause. What that means is we make advances in all areas of science and medicine. When great advances are made, which are terrific things to do, are we leaving certain populations behind? Are certain populations not seeing the kinds of evidence of advancement that we see from screening, treatment of breast and colon cancer, advances in precision medicine, immunotherapy? Are we seeing the same? And in fact, observations may suggest that there are not, and certain populations are being left behind with regard to this progress. Now, preventative interventions are least likely to cause this kind of disparities. And it's quite possible that if we can take more preventative actions across populations, we can afford a more equitable distribution of healthcare. Next slide. So just a little bit of background in terms of how we may think about African American individuals and health disparities. This slide is meant to show for males and females that the differences that may be at least described along the lines of African Americans and their non-African American counterparts, the Black population, the white population, and the rank of different disease states. Heart diseases and cancer certainly lead the list. But what's certainly interesting there is to see what the percentage and the death rates, certainly higher. Percentage is 24%, death rate 267 as a proportion compared to 25 and 214 in terms of proportions, again, per 100,000 population. And we see the similar sorts of disparities that occur on the female side. Okay, for again, and again, I just mentioned heart disease as an example, but heart disease and cancer showing, again, disproportionate outcomes, higher rates that occur in the Black females. So we do see that there is outcomes that suggest that there is a greater extent of cardiovascular and cancer burden in ethnic groups. In terms of cancer, kind of looking a little more intensely into this category, of healthcare conditions, you can see that certainly prostate cancer rates most highly among males, females, breast, lung, and others. But this certainly is the highest amount of cases and the highest amount of death rates that occur along the lines of prostate and lung and bronchial. So for men, certainly discussing the outcomes here regarding prostate cancer management is certainly a very topical discussion. Next slide. Now, what about prostate cancer? I do think there is a racial variation. In America, we do see that the incidence is about 60% higher among Black men, 60% higher rate that we see. And mortality rate is even more alarming. That is a sobering statistic. That is about a 2.5-fold higher rate in Black men. So you can see there are disparities here in having prostate cancer and dying from prostate cancer. Why is this so? Well, a lot of factors are there. Let's chat about these here in the next slides to come. Next slide. Here are some factors that are associated with racial variation in terms of prostate cancer outcomes. Why do Black men have greater risk of incidence and death? Well, there are disease factors, patient factors, provider factors. I'm just going to spend a moment on the slide without dwelling too much on all of these, but you can see there's a host of factors that are involved at all these different levels in which there's impact. Patient factors certainly have a role, and even our provider factors. If you look at those in terms of how we provide a service and care to our patients, all of this does have roles. Next slide. And this, I'm going to hone in a little bit more here on some factors that have to do with how we go about healthcare administration and utilization in definitive ethnic populations. So as far as prostate cancer is concerned, there may be a difference in terms of treatment selection bias. And studies have shown that there seems to be a higher odds ratio, 1.4, of this waiting and seeing how prostate cancer may progress, that so-called watchful waiting, than it may occur in the majority populations. Whereas shared decision-making, which is a discussion about informed decision-making between a healthcare provider and a patient, reviewing the various aspects and options for care, taking into account values, preferences, and whatnot that the patient may have. This kind of discussion that goes on seems to be much less in African American populations, 26%, and Caucasian Americans, 52%. So this may also account for why prostate cancer, just by way of selection bias, has a greater threat in African American populations. There's descriptions of treatment delays, but this may not be an issue in equal access centers. There may be a lack of treatment access in terms of health insurance and the availability of medical facilities. That again gets to the access issue. And then there may be some systemic barriers. We know that there are low volume urologists in many places around the world. Among the Black urologists, there are only about 2% of all urologists in America happen to be Black. And many times the individuals do want to see somebody who has a cultural background similar to theirs to receive the best care. So that's something to be aware of. And even, shown at the bottom of the slide, hospital racial composition may play a role. And interestingly enough, some of the institutions that largely have Black populations may have a lesser degree of the best care available. And that, even though Black patients may go to those hospitals, they may end up having less of the best care there. Next slide. So what are the burdens? Well, we know that there are preventable physical and mental health adversity. There may be a profound impact on social determinants of health. And there are a variety of these, which I will show you in the next slide to come. Next slide. We know that in terms of social determinants of health, I think this is an important discussion to have. Okay, and the bottom bullet there makes the point that of all these environmental and conditional factors in which we born, live, learn, work, etc., that ultimately sexual determinants of health may have such an impact that it may be as much as 80 to 90% of the modifiable contributors to our population health outcomes. And what we do in medical care may actually be a much more significant proportion, much lower proportion, considerably. So let's think about what social determinants of health have in terms of impact and where we think we can influence the best care for our patient populations. Next slide. So this is a slide I wanted to bring up here. You can see I've listed a variety of social determinants of health. And this can range from everything from education, nutrition, where we work, our food security or insecurity, healthcare insurance, housing, neighborhood safety, stress, transportation, all of these sort of things can impact the quality of health that our patients receive. So while we may be healthcare providers administering a certain medication or a surgery, we need to also think about how we can bring about the best attention to social determinants. This is more along the lines of preventative healthcare that may have significant impact. I'm pivoting a little bit here because I want to make the point that, you know, there is something to be said about addressing healthcare disparities on a health economics basis. There have been a couple of reports that do make it very clear that if we address healthcare delivery disparities, there would be actually cost savings. In the United States, a study that has been affirmed by two different citations I show you here show that as much as $230 billion annually could be saved in direct medical costs by taking action with more preventative care and addressing some of the social determinants of health rather than reacting after patients have significant diseases, complications, end up in emergency rooms, and therefore these costs would be a whole lot greater accordingly. The cost estimate also may be underestimated if you consider some other aspects that impact financial losses, such as quality of life, uncompensated care, lost productivity, and premature mortality. So very interesting to consider the health economics aspect of this. Now, what about sexual dysfunction outcomes disparities? Getting back to, you know, the kind of discussion we're having here within our sexual medicine societies. You know, the management of prostate cancer does have effects on quality of life. Dr. Mohal very nicely and eloquently described all of the different impact areas, and all men are impacted in various ways with regard to their sexual function. Now, what about the relevance in African American communities in which there is a higher prostate cancer risk, which I've described to you now? And it could have influence on decision making and survival outcomes. In fact, I can tell you in my patient population, as a practicing surgeon and a healthcare provider in sexual medicine, I can tell you that many men within the African American community, and maybe an example of other minority communities as well, is that they are concerned about how treating prostate cancer can affect their sexual function. And perhaps some are dissuaded to proceed with therapy, don't want to get checked up, and certainly may not even proceed with intervention for fear that they would lose their functional abilities in a sexual manner. So all this is very important discussion for our webinar here today. Next slide. And there may be a cultural dimension, okay, in terms of understanding that this has impacts on psychosocial and cultural correlates. And I just show you a couple of studies, and there are many more out there, some other larger studies, but I think these were some ones that I think make the point that it has been shown that there's correlations with regard to cancer-specific anxiety, and this may be higher in non-Caucasian men, according to references shown here. And then an aspect of spirituality, maybe a cultural side of it, that may be greater in African American men and Hispanic men. So you can see these are various dimensions that we need to consider as we evaluate and provide the best care for patients in minority populations. Next slide. So how do we put it all together? I think there is, at least as I synthesize the literature, there's conflicting evidence in terms of the extent and quality of life significance. So it's back and forth with a variety of reports out there in terms of how African American men are impacted compared to their counterparts. Studies in the past have had limitations, variations in study types and designs, retrospective data accrual and surveys, and recall bias, relatively low inclusion of African American men in some of these surveys, whereby it is difficult to assess whether that is truly representative of minority individuals if only a small percentage of surveys really assess what these men are saying. And there may be uncertain methodologic rigor to ascertain certain outcomes. And rigor in how we go about assessing outcomes, Dr. Mohal is very keen about that. I think it applies to all populations, and only in that way are we best informed about the impact. So the likely conclusion is that the extent of sexual dysfunction effects may not differ between ethnic groups, but there may be a psychosocial impact that, again, I think is a likely conclusion, a conclusion that I might draw from the literature. And I think the accuracy of conclusions to date require further investigation at this time. Next slide. So how do we go about management while we still need to do the right studies? Well, I think that certainly survivorship care is what we're talking about here in the arena here of sexual health. I think we need to continue to improve upon our patient and provider communication, understand and recognize, be aware of cultural differences in patients, and certainly take action to identify individual patient psychosocial needs and address these within the psychosocial and cultural context. Next slide. So in an overarching way, I think that from maybe a perspective of healthcare research, healthcare policy, there are pattern of care improvements, the quality of care improvements, and then specifically research endeavors and how we should think about making progress. At the bottom of the slide here, I think we need to continue to elucidate risk factors, biologically, genetic, social, environmental, dietary, lifestyle, a whole range of risk factors that deserve more attention in research. Understand how the impact is versus high and low risk disease. As we manage prostate cancer in general, we have various categories in which we need to accept patients undergoing management. We need to balance how we're evaluating and dispensing care, recognizing the impact on sexual health. And we continue to do scientific work in the area of biomarkers, technologies, and so forth. Next slide. So in terms of future studies, including a larger number of minority men populations, African-American men, and prostate cancer care, as well as sexual health management after prostate cancer management, follow them prospectively from before treatment and after intervals that can extend some period of time, as the impact was even described by Dr. Mohal, can even be in the long-range intervals as well. I think we need to apply culturally sensitive interviews and diagnostic tools. And I think we need to continue to delve into patient-reported factors, reasons for admissions of sexual dysfunction, its father and its impact on quality of life. So these kinds of studies that many of our colleagues are taking for women impacted by prostate cancer and its management, as well as minority populations of men and women, I think we need to consider this broad level of research activity going forward. So I think that's my final slide. And I'm prepared to conclude there. I do appreciate your attention, and I'm very pleased to answer any questions you may have. Thank you.
Thank you very much. Both excellent talks and really thought-provoking. Just a reminder to the participants, any questions, please do use the Q&A button. And also there was a comment in French, and unfortunately I don't speak French. Does anyone else in the panel speak French? Otherwise, if you could write your question in English, that'd be much appreciated. Perhaps just to get the ball rolling.
I got a couple of questions for Bud, Don, if you don't mind.
Oh, please go. Yes.
So, there's a lot of discussion now about healthcare literacy and the discordance between the physician and the patient with regard to language. At Hopkins, are you guys routinely using healthcare literacy assessments of your patients?
Yeah, to answer the question, to my knowledge, not routinely in our clinics. I think we're sensitive to this. And I think we're trying to perhaps start to consider AI tools and various other kinds of ways to help teach us how we should do a better job. But it's not become necessarily mainstream. I think healthcare providers still proceed as they best know how. But these sort of directions, I think, are very important to consider.
Yeah, and at Memorial, we don't routinely use any validated instrument at this point in time, but certainly our interest in kind of socio-ethno-cultural determinants of outcomes, for example, is increasing. And I think we're on the threshold now of using a validated instrument. We're looking at using the newest vital sign, which is Pfizer's healthcare literacy assessment. What's very interesting about healthcare literacy, and I'm not an expert by any means, is that it is an umbrella term for not just literacy, but also numeracy. So we talk to our patients pre-op about X% of men of this and X% of that, but there are some patients who just don't understand even that terminology. So I think that's an important consideration. I don't know if any of the attendees have any comments regarding healthcare literacy. My other question for you, Bud, revolves around the concept of mistrust and the mistrust that exists among ethnic minorities toward healthcare in general. Do you have any comments on that?
Well, I do. I mean, and you heard me speak about how um, the unfortunate truth, and maybe this, certainly is being overly critical, but I think the reality is patients do seek out care providers that look like them, that speak like them, and have a similar background. Now, in my practice, I personally believe that we should be looking after everybody, and we should be open-minded and look after men and women and people of a variety of ethnic backgrounds, et cetera. But patients somehow do have a sense of mistrust. And I think in America, I think there's a lot of background for why that's been so, in terms of a variety of healthcare situations that go back to the Tuskegee phenomenon, Black men being exposed to a variety of unethical treatments, to even things that may still go on nowadays, where there's a perception, perhaps unfairly, of who's getting what kind of therapy. I showed you just how things may differ in terms of prostate cancer management with regard to watchful waiting versus shared decision making. Why does this happen? Well, maybe distrust or mistrust. It may be a matter of communication. Who knows? But all these sort of things do make a point here that do have this impact that translates into disparities. So I think that's a significant issue. How do we address it? Well, I think we need to address it by sensitivity, kind of awareness and taking action. I mean, maybe all of us can do some sensitivity training here and there, and know how to communicate. I think all of us, no matter what your background, could benefit from that potential.
Just following along that line, but if you don't mind, I mean, I know in the UK, for example, people of African descent, Caribbean descent, we actually go over and above because we know that the risk of prostate cancer is actually higher than it is in, say, white Caucasians or white British men, and therefore, and we do have outreach programs. So having, men who've had prostate cancer, African and ethnic men who've had prostate cancer, who then go out in outreach programs to try to connect with patients for testing and things like that. I mean, in either of your institutions, do you have programs like that? Is there something that's even possible within your jurisdiction?
So in Waterstone Kettering, we have a predominant Caucasian population. All other ethnic minorities are a minority within our institution. We do have affiliations with hospitals like Jamaica Hospital, which has predominantly African American, Afro-Caribbean population. So certainly we have that kind of outreach for sure. But we don't have the kind of program at this point in time that you've referred to.
Yeah, I would have to say that I think there is an awareness, but perhaps a little more proactivity is needed. We do have within the Department of Urology what's called a Schauffeld program, which promotes bringing along some more community outreach, also trying to help bring in young individuals to have opportunities to go through medical school training and so forth. I think some of us may do a lot of individual activity. Say it, I'm probably at a church maybe once or twice every weekend, in communities, speaking about their best health care and so forth. So it may come down to just a couple of us champions who do a lot of work on the side. But I do think institutionally we could continue to do a better job. Absolutely.
Great, thank you.
John, I had a question for you as well. You mentioned some of the outcomes here that you had shown with your research, which I think is very illuminating. I wonder, is that data largely specific to the pre-robotic era, or both open robotic, post-robotic, in terms of some of these outcomes, and how would you kind of interpret your data with some of that?
I presented the Capogrosso data, which showed no difference when you look at open versus lap/robotic surgery, albeit that was just up to, I think, 2016, if I remember correctly. But it's predominantly robotic surgery now, as you know, nationally, and I think increasingly internationally. I'm not aware of any data that robustly supports the concept that robotic surgery improves oncological, urinary, or sexual function outcomes. I just think that it is uncommon for a trainee to be trained in open prostatectomy. Do you still train your urology residents in open prostatectomy at Hopkins? Bud?
No, we're starting to back away from that. I think it's an unfortunate thing in some respects, because I think that, that you're not going to always have these opportunities worldwide. I can tell you, I do a lot of, as you know, Ron, John, I travel here and there internationally, spend a lot of time in the Africa, Caribbean, working with urologists, training them about surgeries. They don't always have robots here in some of these places. And so I think that having these skills, I may be one of the last guys running around who can do pretty much it all. But I think we're in a very privileged society, some of our Western societies, and still having these skills for open surgery, I think, is still important. I think sadly, a lot of my residents just kind of like, oh, I've never seen that before. I don't even know how to get into a pelvis. I mean, that's just, oh my gosh, that's just something very unfortunate, sadly.
Yeah.
But I do want to comment
Few
on
questions, please.
Oh, we have additional question? Okay, well,
Yeah,
let's go with the other question for now.
Yeah, I would like to ask Dr. Mulhal a few questions. First of all, what do we know about L-arginine? Many people talk about it. I know that there are some research about it. So can you?
Yeah, so listen, L-arginine is a nitric oxide donor, right? And I think, the biological plausibility and why it's promoted as an erectogenic agent is very obvious, because NO is the primary neurotransmitter, right? Science Molecule of the Year, 1983, right? Just Say No was the cover, that famous cover. The problem with nitric oxide and Bud, of course, is the world authority on nitric oxide, is, it just doesn't have a very long half-life. And I think if you take it orally, the chances of it really getting to your corpus cavernosum and being an erectogenic agent is very low. You'll get venodilation. People use it before going to the gym and they look pumped up, but really it's not an erectogenic agent. There was a lot of interest in nitrosylated drugs about 15 years ago, attaching nitric oxide to PDE5 inhibitors to augment the response in those who were not able to mount a nitrogen response, such as diabetics and radical pelvic surgery patients, but that went nowhere. So I think that, Bud, do you have any comments on nitric oxide donors?
No, I think that remains of interest. I think biologically this is important. I'm not quite sure that we've been able to figure out in our scientific community how to repackage this in something that really can drive nitric oxide in a way that's really therapeutically beneficial. So you said it just beautifully there that, I think there's a lot of promotion out there about this L-arginine, which is a precursor to nitric oxide. Indeed, you're right. I did all the science on that 30 years ago. That I know much of it. But
I mean, I think Sharon, that any erectogenic agent, whether it's a pill or a device, shockwave therapy, PRP, stem cell therapy, should be held up to the standards that PDE5 inhibitors have been held up to. Large, randomized placebo-controlled trials with good characterization of the patient population, validated endpoints. And I think that just doesn't exist for any of the over-the-counter supplements. And I think the AUA guidelines in ED, and Bud co-chair that panel, suggest that we should not be using these kind of agents as primary treatment for ED. I think you had a second question, Sharon.
Yeah, so it's kind of connecting, because I'm happily recommend the MSK protocol, the PDE5 inhibitors immediately after surgery or radiation, But people ask me in Israel, how can it be that it's not a global standard, like a regular basic? So how can you explain that?
It's an excellent question. It's not that it's not a global standard. It's not even a US standard. So
how can you explain that?
Yeah, because, well, I think there are a few things. I'll be very interested in Bud's take on this. I think there was originally cost concerns. That's no longer, at least in the United States, that's no longer a concern, because these medications are actually very cheap. I think there was this argument that there is no level 1 evidence-based medicine, but I think if you were honest with oneself, one would ask, what do I do on a daily basis in my medical practice that doesn't have level 1 evidence-based medicine behind it? And that's a fair number of things that we do. And then ultimately, rehabilitation, as you know from spending 3 months with me years ago, is cost, energy, labor, and space intensive. And if you don't have an infrastructure that supports a rehab program, you need a champion, me, but you need people below me, my nurse practitioners, who run this program. And it's quite burdensome to do. So there's an apathy among not just clinicians, sometimes patients, but institutions into buy into the infrastructure that will support a robust rehabilitation program. Interested in Arthur's take on that. Bud?
Yeah. Oh, well, I certainly commend John for all of his work in this area, because I think it's a very important subject area. Addressing men recovering from prostate cancer management as a rehabilitation kind of framework that we're doing. How we're defining it, I think, essentially is correct. That we want to improve guys' recovery. Now, how we do it, I think, is something that we're still trying to do. And of course, as John says, labor intensive and so forth. But I think at the same time, I think PD5 inhibitors conceivably have some benefit. They've been shown, particularly in animal studies. But I want to make sure that we understand really how impactful it truly is, at least on a biological level. While we may be wanting to support our patients, I want to make sure that we give people the right expectations about how well it's going to improve their true function and not let it cloud any further discoveries that should come along if we actually do things as scientifically rigorously as we should to bring about new therapies.
If I could just make one comment, Sharon, that there are two randomized controlled trials that show that if you engage the cancer patient in quality of life discussions, irrespective of the outcomes, their quality of life is improved. By we engaging in this discussion with our patients, and this is entirely consistent with the ISSM Movember guidelines, engaging with patients alone, irrespective of, let's say, sexual function outcomes, will go some way to improving their quality of life. What ends up happening is that patients often say, and their partners increasingly say, we feel unheard, that we are not, this is important to us, but it's not being addressed.
Great points. Can I just bring in the audience? So there are two questions in the Q&A. The first question is, do you think that disparities in access to research centers could lead to a lack of data on minorities affected? Has there been any conscious effort to decentralize research to rectify this problem? Bud, if you could take this.
Yeah, well, certainly that hits right on my presentation, and I think unfortunately there has not been enough good attention to do this sort of thing, and I would have to echo my comments and applaud the questioner here that we need to do a better job. Perhaps even in our societies, we need to think about how we can be a little more focused about doing a much more attentive way of going about research and getting the right data and having impact.
Great, thank you. And probably for John, is there any role for pelvic floor therapy in addition to penile rehabilitation before or after prostatectomy?
I would say, and no one's ever accused me of being gray on any subjects, right? So I have strong feelings about pelvic therapy as an erectogenic strategy. There is not a great biological plausibility there. And so I'm not aware of any robust literature that shows definitively that there's a role in pelvic floor therapy in sexual function. In erectile function. However, from a continence standpoint, there is good evidence to show that pre and post prostatectomy pelvic floor therapy, whether it's patient-driven Kegel exercises or biofeedback with a pelvic floor therapist, is supportive of continence recovery. And in the sexual medicine space, that would include arousal incontinence. So if you have sphincteric incompetence, you're at increased risk of having arousal incontinence, which is very distressing to some couples. And so I think, yes, in that space, pelvic floor therapy has a role.
Great. What about rehabilitation? Because I know you spoke a lot about the recovery after and how we can have penile rehabilitation. What about prehabilitation? And what are your thoughts about this? Perhaps open to both John and Bud as well, please.
Maybe
ahead,
I can start that off. So the whatever literature exists to support prehabilitation is animal-based literature. The rat cavernous nerve injury model suggested that if you pre-treat the animals with a PD5 inhibitor, that they have better erectile function recovery than treating the day of the injury, right? There is, however, biological plausibility behind this, and the concept is called endothelial preconditioning, that you take a nerve injury and there are structural and functional changes in the endothelium in humans after prostatectomy in response to nerve trauma. And if you can upregulate and protect the endothelium by prehabilitation, then there is an argument in favor of doing that. Is there randomized placebo-controlled trial data to show that? No. Will we ever have that? Almost certainly not. Very expensive, very challenging studies to do. So I think we're going to be stuck with, the whole concept of extrapolation science from the concept that PD-5 inhibitors are endothelial protectants and the animal data that we have. But in an era when, at least in the United States, sildenafil 20, 25 milligrams or Cialis 5 milligrams is very cheap, then why wouldn't we do it? And remember the cloner data, right? Bob Cloner, cardiologist, suggesting that those men who are using daily PD-5 inhibitors, or at least frequent PD-5 inhibitors, are at lower risk of major adverse cardiovascular events. So why wouldn't we be doing it? But
Yeah, my thoughts on that subject matter is that, yes, I think it's good to support our patients. I think, as John has already said, this having that engagement with patients postoperatively as well as preoperatively likely is going to derive some sort of benefit. It's certainly not adverse. The question is giving patients the right expectations and really what's biologically impactful about some of this. Right? I do have to kind of wear the scientist hat with some of this. While still being a clinician too. There's an art in science to medicine, I guess, right? So I believe in yes, counseling patients, but also helping them know that if somebody's critically said, what's the evidence that this scientifically has that kind of impact? I would say, well, we still need to study it, and we need to bring about better therapies and really achieve the purpose.
Remember, I had a slide that says we should be doing this until such time as we have data that supports or refutes it. At this point in time, the absence of data saying that it's amazing, that it's incredibly beneficial to rehab, doesn't mean it's not. And I don't think, Don, that we'll ever have that trial. That's a multi-million-dollar trial that's going to be very hard to enroll for. We tried to do a rehabilitation trial at Memorial Sloan Kettering. It took us 3 years to get it through the FDA and the IRB at MSK, and it took us 3 years to enroll 43 patients, and we got shut down by our data safety monitoring committee because it was taking too long to enroll. And so patients coming in at Memorial, at least, they don't want to be in a trial. They say to us, what are you doing on a daily basis? That's what I want. So if you introduce the concept of a placebo-controlled trial, it's very challenging to enroll patients in this space.
I mean, I know one of my colleagues, Jeff Hackett, which I'm sure you guys know as well, he says, PD-5 inhibitors should be in the water for everyone to take. Slightly controversial. There's another question here for John. So thank you for bringing up the subject of illiteracy. Can you say something more about how you can address these cases when you suspect that there may be a problem that affects communication?
Yeah, it's a really, really interesting question. I will tell you, there is little doubt in my mind that those patients who are non-Anglophones, right, whether it's speaking Spanish, Russian, Bangladeshi, whatever it would be, have a poor understanding. This is 29 years in the business, have a poor understanding of what to expect post-prostatectomy. So at Memorial Sloan Kettering, we have professional translators. Friends and family are not allowed to translate. And we have a host of professional translators, whether they're employees of Memorial or contracted, who come in and help. And there is no doubt that they are better than me speaking to the patient. But is it the same as a native speaker, physician speaker in the same language, coordinating that patient's care? And my honest opinion is no, it's not as good. So we've had, for example, patients come in to see us who speak very rarely spoken, peculiar languages, that we do our best to try find native speakers in the urology space who can help them, because I believe that it is almost impossible to communicate the nuances. Let's take, for example, a conversation about you need testosterone to make PSA. You have a patient post RT ADT with a castrate level T whose PSA is undetectable, and the discussion about, I don't know what your PSA really is, Mr. Jones, or whatever the name would be, because your PSA is below saturation point. That is a very complicated conversation in an English-speaking patient and an English-speaking physician. Can you imagine what it's like if you have a Hmong patient or somebody from Albania and you don't have a facile translator or an Albanian speaking physician? Very, very challenging. And this is, I think, at least in my space, sexual medicine in the prostate cancer patient, largely unaddressed in the literature.
No, I would echo those comments and also make the point that it's not always just ethnic populations. You know, I have patients who are right here in Baltimore, Maryland, who you know, may not have had a high level of educational attainment. And I think it just is important to try and at least take a moment. And I learned this from Dr. Walsh, who's one of my mentors early on, which was, you know, take a moment to not just to take a look at the patient and draw your conclusions. You know, I've seen patients that come in that are, you know, very ethnic, African, whatever, and they're extremely educated. So we can't assume anything. We need to just take in when we initially discuss to a patient, you know, have a brief conversation, understand where they're coming from, what their level of understanding is, and again, maybe we all need better sensitivity on all of this, so that we can figure out what kind of conversation makes sense. Some patients, the depth of the conversation may not matter much to them. They just need to hear something essential. But I think John's absolutely right that there are some nuances that may be cultural in some cases, things that we kind of almost automatically think make sense. And that's just not so. So we have challenges. There are challenges.
I would strongly encourage all of the attendees to go and take the newest vital sign questionnaire yourselves. It's 6 questions. It's sponsored by Pfizer. It's called the newest vital sign. It basically has a food label and asks you questions that are literacy and numeracy targeted. It is not easy as an English speaker. And I think that it really highlighted to me how difficult it must be for somebody who is not an Anglophone in reading material, et cetera, et cetera. We have lots of our reading material at Memorial in Spanish and in Russian. There are 2 very large populations in the non-Anglophone group, right? But we don't have literature in Albanian or Bangladeshi. Everything in those languages that I've cited are written at the 6th grade education level. So they go through a committee and they're really brought down to a level that almost everyone who speaks that language can understand.
As a Jewish, I can tell you that I feel that it's much more than a language. It's a culture, it's a codes, it's priorities, it's behavior, it's way of thinking. It's so many issues while you are taking care of minorities. And you
I
have
think
to
that's a
learn
very
that
important.
population.
Yeah, I think it's a very important point, Sharon. For example, if you look at the SEER Medicare database analysis of penile implant utilization after radical prostatectomy, it is significantly higher in those patients who are African American and Hispanic. So there are no doubt there are cultural factors that play into some of this decision making. I don't know if Don, if you have that experience over with your very multicultural group in London.
Not really. I think, you know, in our experience, because, you know, we do have professional interpreters. So very often, you know, even if we don't have an interpreter present in person, we have easy access to phone interpreters. You know, we do with the outreach programs try to, and we have the pre-surgical schools that we run as well at UCLH, where we do try to address these cultural issues as well. So, you know, I haven't really had a lot of experience with that sort of disparity as such, but certainly, you know, I think as clinicians, it's really important that we are cognizant of these differences and agree with Sharon, it's not just a language, you know, and I think something to bear in mind. Can I just ask maybe Bud one last question, and maybe we might wrap up the webinar soon. I know that John posed a question about neurorehabilitative medications that you're sort of running research programs on. So would you be happy to give us a minute's, you know, synopsis of your, you know, what you're looking into and your current investigations in that area?
Certainly. Well, I'm glad to share with you that. You know, as you allude to, I've been a surgeon as well as a scientist and kind of a bit of a entrepreneur of sorts over the years. I'm always thinking innovatively about what we're doing next. And what we've actually been able to do now is start a trial now where we can put these implantable electrodes in the pelvis at the time of radical prostatectomy. And this follows some original kind of proof of concept studies I did about 20 years ago. We went on to do this in rats where we put these implantable electrodes about 10 years ago and followed the rats, waking them up, and then brought them back for kind of erection studies a week or more later. And the rats said we had these implantable electrodes in the pelvis in a condition that's similar to, how we inflict a nerve injury with radical prostatectomy, so it mimics radical prostatectomy. The rats that had these implantable electrodes with handheld stimulators over the week or so with daily regimens of stimulating these electrodes and animals running around in their cages. The animals a week later had better erection recovery. We're now doing that in patients, brought it all the way up to in a translational way to human beings, post-radical, and we're seeing much earlier recovery of erection. So at least early on, we're seeing that. It's a trial we're doing in collaboration with a group in Australia as well. So we'll be able to kind of share something more about that, I think, in a year or two to come with enough follow-up to really see whether we really are seeing an improved outcome. And if we do, it meets what John has been saying here about, the nerves get traumatized, the tissue gets damaged. If we can regenerate and heal the nerve tissue and recover what they're doing in terms of deriving the best health of the tissue, hopefully we'll have less of a damaging effect in those patients and recover their function in a better way that is earlier recovery, but also prevents kind of the destruction that occurs because of the late recovery.
But I think I know the answer to this question, but when did that research start?
When did the research start? I guess
many years ago, correct?
Yeah, I've been doing it for 20 years, but
Right.
I get there's different stages of it. But the human trial, we started at Hopkins about 5 or 6 years ago, put on a hold. The FDA said they wanted more toxicology studies on some of the stuff that we're going to put in people's pelvises, and so you see it's been a long journey. It's been a long journey.
So when we talk about doing these studies, it is a decade or longer, 2 decade, a journey, odyssey in regulatory agency requirements, IRB requirements, and getting the data. So, I think that any new questions we have today, if you're going to answer them correctly, it's going to take investment. And that's not just physical investment, that's financial investment. It's hard to do these studies without good support, for sure.
Got
Perseverance. Got to persevere.
Really good point. What about sural nerve and nerve grafts? I mean, obviously there were, the Melbourne group, I think, published on sural nerve grafts a few years ago, and then there've been more recent abstracts anyway, particularly SMSNA, for example. I mean, do either of you have any experience with nerve grafts? Have you done them?
Sure.
Do you think they work?
We've published
I can answer.
papers in the nerve graft. I'm sorry, but go ahead.
Yeah, I was going to briefly say this to be brief that, certainly there was a lot of interest in this. Dr. Scardino at John's place was big into this 20-ish years ago, 15, 20 years ago. Dr. Walsh perhaps claimed that he had done that initially with a genitofemoral nerve graft. The problem is that what are you grafting in the pelvis? These nerves are diffuse, they're small. Are you grafting sympathetic nerves? Are you sympathetic what really are the proerectile parasympathetic nerves, which is what you really should be doing? And so this is the quality of these nerve grafts, how you're doing it, the success with them. And also in our modern era, since many men really have the opportunity for true nerve sparing these days, what is the role of nerve grafting? And they may be there for some that have more extensive disease, and maybe we have to offer that. But I think this, in general, I mean, there's a lot of discussion surrounding all of this. I think it's a good idea. I think you got to perfect it. It may be a role, but we got to do it better.
So I think this is an area that was present 15 years ago, went to sleep. And I think just like Bud's neurostimulator research, you're going to see more interest in this. Now, remember that this is for men, ideally, who have deliberate bilateral nerve resection. So 85% of prostatectomies at Memorial are nerve sparing on both sides, right? So some degree of nerve sparing on both sides. So it's a small population who would be candidate. But remember, with stage migration, we're seeing increasing numbers of patients who need deliberate nerve resection. So I think there is a rationale for it. I think the literature would suggest that if you have absolute deliberate bilateral nerve sparing, that your ability to respond to a PD-5 inhibitor is between 0 and 10%. And in that 10% group, clearly the nerves weren't completely resected. Okay. So I think that if you were given the choice, Don Lee, of having deliberate nerve resection because of your cancer and your sexual function, your erectile function was important, I think many patients would say, if you could take me from the 5% range to the 15-20% range, then that might be a benefit. And that's the figures we saw with our bilateral sural nerve grafting, sural/genitofemoral nerve grafting at Memorial Sloan Kettering. There's a company called Axogen who are about to start a multi-center trial. I think, Bud, you've been in contact with them also. And so this is a nerve graft, an interposition nerve graft that would be done at the time of radical prostatectomy. So I don't think the jury is in yet on whether this is viable or not. I think it's technically viable, but I'm interested in seeing data from large randomized trials.
I think
Let me just add that one of the things we have to do is really understand really what this cavernous nerve anatomy is all about. And that's another project I've been working on for years. And we've been working on now the latest in terms of cavernous nerve mapping, intraoperative nerve monitoring, and really understanding where are the prorectal nerves, anti-rectal nerves, really describing that, and I think in a level that's never been done really well. And so if we can do that well and really show what nerve we should be grafting and where these nerves are, and actually do the right nerve grafting, that'll probably bring forth maybe a goal for nerve grafting.
Exciting times, I think,
Yeah.
right?
People really love the presentations. They wrote it. So thank you very much, everybody.
Have a good day.
Thank you, guys.
Have a good evening.
Everyone.
Bye-bye.
Cheers.
All right.
Bye-bye now.
Thank you.
All right, bye now.